This is a 35-year-old gentleman with gastric outlet obstruction secondary to severe duodenal stenosis caused by a non-healing benign duodenal ulcer. He has lost 20 pounds in weight over the last 4 months and is unable to tolerate solid diet. This gentleman is currently an inpatient requiring TPN. His case has been discussed with the surgical team and have declined to perform gastrojejunostomy for benign indication. He presents today for endoscopic gastrojejunostomy. I now hand you over to Dr. Haber.
Yes, hello everyone. Sorry, I think you can barely see me over these monitors. So we do set up 3 monitors, by the way. We like to have, obviously, EUS to guide us for the puncture of the jejunum. We have fluoro, which we use as adjunctive way to determine our position. And of course, we have the endoscopic image. So hopefully, at some point, you'll be able to see all 3.
Thank you.
So the real issue with GJ is having a target. And to have a target, you want something water-filled for EUS. Let's put the nasal-biliary on, please. We want a water-filled limb that we can target. And the wider that target and the bigger the limb is filled with fluid, the better the chances that we'll be successful. So the way we do that, I mean, there are many ways. There's the balloon that Itoy developed, the double balloon technique, a special catheter with a balloon beyond the ligament of Treitz that gets blown up, and a balloon in the 4th part of the duodenum. And then you just fill up the limb around the ligament of Treitz with fluid, and it's locked in by the 2 balloons. I think we're going to hear tomorrow about an exciting through-the-scope double balloon development, but I won't preempt that lecture. You'll see that tomorrow. So basically, in lieu of the balloon technique, which we don't have, we're just going to overwhelm the jejunum with fluid, hopefully to fill up the limb. And the way we do that, we put a nasal jejunal tube in, which is basically a nasal biliary tube that we put down, which is what we're doing now. We have a wire beyond the obstruction. He has a weird anatomy. His ligament of Treitz is way up under the diaphragm. So what we're seeing is, if you've got the fluoro image to look at, you'll see the scope sort of at the mouth of the duodenum. Then the wire goes down the 4th part of the duodenum, sort of takes a vertical direction straight up, and then the jejunum comes straight down. So there are 2 limbs that are back to back. It took us a while to get oriented to this strange configuration. But so we'll have to see. I mean, basically, in order to do this, we need a target. Hopefully, this will give us the target. So now we have a 7 French nasal biliary. So we're going to advance this. Let me just do this. Okay. No. Hold on. Don't pull in the wire. Fluoro, please. I want to leave that wire down as much as possible. I can see endoscopically where I want to be. Now, is the wire through yet? Yes. The other end? Okay. If you look with me at the endoscopic image, keep the wire there as we advance. And we'll advance down, keep going up. Okay. So the idea is we're going to have this, if you like, orojejunal tube. There we go there. We'll stay close in. It's got a loop on the end of it. And we're going to follow it around our wire. Can we mag up over the wire, please, so I can see where... Okay, that's good. We're going to go back up. Okay, pull back on the wire just a bit. Okay, hold on. I want to make sure we get around that tight bend of the D1, of D4 and the JJ1. Okay, hold on. Back with the wire a bit. I can see it now, just rounding the bend. You may not be able to see it. You may not have as good resolution. It's now around that bend at the ligament of Treitz. It's now descending a little. The wire's being pulled. Keep coming. I'm going to try to back on the wire a bit more. Let's see if we can get it to go further down. Hold on. I'm going to push forward here to give it a little bit of a boost. There we go. Okay. Back on the wire a bit. Now we'll go off of the mag. I just want to see what's happening as we get into the proximal part of the jejunum. Now, I'm not sure. Can we rotate, do you think, to see the bottom here better? We have 2 loops which are the other way. Go the other way. If we can rotate, yeah, we might be able to uncover that. There we go. No, center that. Yeah. There we go. Okay. I think
Could
we're
we get the fluoro image shown, please?
Yeah, fluoro image for the audience. Okay. So now pull back on the wire more. So we're going to get the wire, which is down there. Pull back. I want to see where my loop is. Back on the wire. See, stop. So now you can see the catheter looped around at the bottom of that part of the jejunum. I think that's going to be a good place to fill up the jejunum, which is, we can see the stomach, the air in the stomach behind. So that's where we're going to be with the EUS scope. And hopefully we're going to find a target. We're going to look. Okay. And
they can go back to
we'll just pull back on the wire.
potentially.
Back.
Let's see if 5 is ready.
Back a little bit more. There's the wire coming back more. Okay, okay, back. Maybe hold on there. Okay, I'm going to come back a little bit here. Push my catheter forward. I'm not 100% certain where the tip of the catheter is, but back on the wire more. Okay, there we go, there, back. Because it'll form a loop once we pull the wire back. I think it's right at the bottom there. I think that's where the loop is.
Okay,
I think.
I'll let you know.
We'll see. I'll bring the wire back more. A little more. Yeah, I think the loop is there, right there at the bottom. You see that loop? You can see the bottom of the catheter. Okay, so at this point, what I'm going to do is I'm pulling back on my catheter, pardon me, advancing my catheter, and leave the wire there for now. We're going to come back in the stomach
a little bit.
You can pull the wire back a little bit now. I just want the wire in as I pull. Okay, we'll just come back. Okay, hold it there. Now, just a sec. I'm going to grasp it here, and you're going to advance that wire all the way down. Now, let's see. Right about there. Hold it there. There, I don't know. There's one. Hold it right about there. Let's see if we get the. Okay, we're going to go for it here. Okay,
nice. Very good.
Okay, now we're going to release the battery. I want to release
Distal
that.
flange.
Just unlock it here for a second. Okay.
Greg, can you walk us through how much you advanced
Well,
then prior to deploying? And
yes, I will in a second. Yeah. It's opening up here slowly. Let me push it in a bit. Just a minute. Okay, now we're open up. Good. So usually,
that's
obviously, the worry is if you put too much cautery, you'll go through the opposite wall. And in this case, so once I'm through into the limb, I stop the cautery, but I keep advancing the catheter to the opposite wall to give me more room to open the flange. So now we've got a wire here that we can fluoroscopically, let's go to fluoro. We put a wire into that limb as a kind of a safety margin. We'll have it in there. Okay, that's fine. And now what we're going to do is pull back on our catheter against the wall. And see, should be against the hold it there. Well, I'd like to get a little bit of a tenting. There, and you can see the wire down near the upper flange, which is where we want it. So now we're going to release the rest of it inside the scope. We'll go to a endoscopic view. There we go. I'll put a little bit of water in the stomach. I'm going to release this into the scope now, the remainder. Got to be careful it doesn't pull back. It's just a sec. Pulling back. Pulling back, releasing in the scope. You can actually push it out from here too. I'm just blowing up the stomach, looking to the right. There we go. Pushing it out slowly. Looking right. It's a 20. It takes a little bit more to get it out.
There you go. It's right there. There you go. There you go.
I'm pushing it down from the top there. Now, what I would love to see is blue fluid. Come on, blue. Okay, we got fluid, maybe contrast. Okay.